Here we go into the next topic. A heart sounds, baby, coming at you. Now, you have to understand. This is my favorite part, man. It's my favorite part because this is the first place I started with Dr. Shah, man. The great Dr. Shah. This is our first conversation. He taught me heart sounds. And I could not believe that at the end of the short lecture he gave me on heart sounds, all of a sudden I understood it. I said, you got to be kidding me. That I can understand this in just a 1-hour session that we're having, and I couldn't understand it in 4 years? Oh, man. So you know, this brings back fond memories. All right, let's see. Cardiac physiology. Where are we? There we go. So, Beanish, she says she likes cardiac, so I'm going to turn her into a cardiologist within the next 2 hours. Linda is going to be the other cardiologist. I'm going to turn them both into cardiologists in the next 2 hours. Watch how I roll, man. By the time I get done, they're going to be talking like cardiologists. Guaranteed. All right, ready? Here we go. Here's the background, the heart of the matter, man. You have 4 heart sounds. S1, S2, S3, S4. Let me start out by saying this. The language of the organs, the concentration gradient of the organs, we say pressure gradient. So that everything is written in pressure. Pressure, 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 pressure. All right? So atrial pressure, ventricular pressure, systolic pressure, diastolic pressure. Everything is called pressure, but I'm going to tell you this. Pressure can be one of 2 things. It could be resistance, or it could be volume, or it could be both. That's the way I'm going to talk. So different from your books, okay? Because I want you to understand there's a difference. The one that's caused by volume, you need to know that it's volume. If you want to find the best answer, you better know your answer would be talking about volume, okay? Such as that, central venous pressure. Yeah, they call it pressure, but watch what happens. You pick resistance on the exam and see if you get a point. 0. So I'm going to tell you what it really means when we get there. All right, so whatever's resistance, I'll tell you. Whatever's volume, I'll tell you. Whatever's both, I'll point it out. All right, so 4 heart sounds. First, we're going to start out by using the language that your books are going to be used, and then the test question is going to be used so you get used to it, okay? So I'm going to say everything is pressure. So here are the 4 heart sounds. Let me start out by saying this. None of these 4 heart sounds, Kathy, none of the 4 heart sounds. 1, 2, 3, 4. How many heart sounds are there again? 4 heart sounds. That's it. I saw her put her 4 fingers. She's telling me the truth. All right, so none of these 4 heart sounds, folks, are caused by the opening of a valve. Hear me one more time. None of these 4 heart sounds are caused by the opening of a valve, which means if I ask you a question about one of these 4 heart sounds, and I hear you use the word opening, I'm going to stop you right there. I don't care how good your explanation is. It's not the best answer, so I don't want to hear it. I want to hear the other one. That's the right one. Everybody understand me right now? Same thing on a test question. If you see an answer, talk about opening, stay away from it. Sure, you can make that the right answer, but you won't be getting any points for it, so I'm not interested. Does everybody understand me? Okay. So we have S1, S2, S3, S4, 4 heart sounds. Kathy, how many heart sounds did I just say? 4. That's it. 4 fingers. Did you guys see that? Yeah, 4 fingers. Okay. So S1, S2, S3, S4. All right, so let me talk it through first round. Don't write a thing. Don't even jot down anything. Just listen to me. Go through it, and then we'll go through it again, step by step. All right, S1 is a sound made by closure of the mitral and tricuspid valve. Well, who's going to close first, Dr. Francis? The mitral valve. How do you know? It's on the left side. Left side has higher pressure and higher resistance, and therefore it's harder to keep it open, so it's going to close first, followed by the tricuspid. How do you know the tricuspid valve is going to close second, Dr. Francis? Well, it's on the right side. Lower pressure means lower resistance. It's going to stay open a little longer. All right, then after mitral and tricuspid valve closed, then you have a period of time where we call isovolumetric contraction. That means the same volume in the ventricle, and yet these 2 are closed and these 2 are not open yet. All right, then you have pulmonary aortic valve opening. Who's going to open first, Dr. Francis? Oh, the pulmonary. How do you know that, Dr. Francis? It's on the right side, lower pressure, lower resistance, easier to open. Followed by aortic, who's on the left side, higher pressure, higher resistance, harder to open. Then you have systole, 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 bam! All of a sudden, aortic and pulmonary valve closed. Who's going to close first, Dr. Francis? Aortic. How do you know that? It's on the left side. Left side has higher pressure, higher resistance, and therefore it's harder to keep open. followed by the pulmonary, which is on the right side. Lower pressure, lower resistance. It's going to take a little longer to close it. And then at S3, then the tricuspid and mitral valve will open. So after you close aortic and pulmonary, you have isovolumetric relaxation, and then tricuspid valve will open first. How do you know that, Dr. Francis? Right side. Lower pressure, lower resistance means it's easier to open. Followed by the left side. Higher pressure, higher resistance, harder to open. Everybody follow that? All right, so here's all you really need to write down. Because I'm going to be talking about a lot of things. But this is the only one you get to write down. So write it down and then write no more. The rest is application as far as I'm concerned. You can write whatever you want. I'm just telling you. Here's what you really need to understand. The big concept. The big picture is always first. The right side has lower pressure and resistance. Pulmonary. The right side has lower pressure and resistance, and therefore will open first, close second. The right side has lower pressure and resistance, and therefore will open first, close second. Then we flip it gently to the left side. The left side has higher pressure and resistance, and therefore will always open second, close first. The reason I'm telling you that, folks, I want you to understand what you see before you. I want you, as you walk out of here, be able to recreate what you just saw before you. I want to run into you at the grocery store and ask you, and then you spit it out again. I want when they ask you a question, you don't try to memorize, you just remember where everything happened, and you can answer the question. When we get to murmurs, folks, if you know where all these valves open and close, look at that. Murmurs are easy. Very, very easy. This way you don't have to be guessing who's systolic, who's diastolic. If you know where they occur, it's an easy question. Does everybody understand me so far? The only time what I told you may be wrong is if somebody has pulmonary hypertension to the point where blood flow reverses. And that's called Eisenmenger syndrome. In Eisenmenger syndrome, Ferdy, you have a left to right shunt. And then, Linda, you develop pulmonary hypertension so high that blood starts flowing in the opposite direction. Then everything I just told you will reverse. However, Tim, that is shortly before this man's death. So, folks, on a test question, you think that's what they're really asking you about? This guy shortly before he dies? I don't think so. They're asking about the other 99.99% of people where what I just told you will never change. Everybody understand that? That means even if you forget about Eisenmenger, I don't even care. You only miss one question. The other 85, you'll get them right. Okay? That's the key. Know your physio. Cardiac physiology is the largest area on the boards and is the lowest score nationwide. Boards 1, boards 2, boards 3, and board certification. What does that tell you, Nicole? Most physicians never figure out cardiac. Everybody just fakes it. I remember when I was, I think a fourth-year student, and I went to a cardiologist. This was before I met Dr. Shah. And I said, man, I don't understand squat about EKGs. I said, but you're a cardiologist. I know you understand this stuff, but I want to know everything from you. I want you to make me another carbon copy of you. I want to know everything there is to know about EKGs. You know what he told me? He said, take the stack of EKGs, memorize it. I said, you mean I took a rotation just to memorize a few EKGs? You got to be kidding me. I said, so that means that's how you got your degree? MD, bunch of other letters after that? You just memorize your way through, but you have no idea what an EKG really is. That's the sad truth. All right, that's the sad truth. One time I took students up to the hospital right here in town. This was when there were like 5 of you. Can't take you guys to the hospital now. And then, of course, with the HEPA laws, I can't take anybody up there anymore. But they used to allow me to bring students up there. ICU is the best place to see physiology. That means everything I teach students, I said, now, let me take you up to the hospital. You see if what I just taught you was wrong. And then we would just pick charts at random. I said, what do you expect to see in the serum sodium? All of a sudden, they say low. I said, well, here's what the chart says. It was low on almost every chart we picked up. Just to let you know, on the test, folks, if you pick anything else, you are taking a chance. I don't care what your first day or any other book says. Low volume state. 9 out of 10 Americans don't drink enough water, even if they're in the hospital. Hyponatremia on almost every chart. All right, so I was doing EKGs with the students. I started teaching them physiology of an EKG. There was a cardiac surgeon over here to my left writing in the notes in his chart, or so I thought. But he stood there for the whole hour and 15 minutes. I was teaching them EKGs and physiology. I was like, man, that's a long soap note you're writing. But, I'm like, hey, he must be a very important patient or something. After I finished giving the discussion, teaching what a P wave was, PR, just like I did for this class. You see how excited you guys got. I mean, he walked over to me, and he shook my hand. He said, I just want to meet you. And he introduced himself to the students. He said, you know what? He said, that's the best explanation of an EKG I've ever heard. He said, I've been a cardiac surgeon for 25 years, and I've never understood EKGs. Now, you got to understand, the man still practices right here in town, but he knows EKGs now. But the good thing was, I give him a lot of credit because he was at least able to admit it. You know how many doctors never admit it? And you and I know, doggone what, they don't even know what they're reading. They just, whatever the computer says, that's what they say. Yep, it says AFib right here on top. But they don't know what AFib really means, okay? All right, so you're going to learn it from here. Everybody understand? Here we go. Now, the sound made. Remember, pressure is a gradient of the organs. The sound made by popping a valve open, Tina, during diastole, it's called an opening snap. Tina, do you hear what I just said? When you hear an opening snap, Tina, it means you're popping a valve open during diastole. During diastole, what's going on, Tina? You're trying to fill your ventricles. So if you have to pop a valve open during diastole, Tina, is that valve stenotic or regurgitant? Must be stenotic. Does everybody understand? We're going to reason things out because I don't want you to memorize anything I tell you. All right? I want you to know it here, 10 years from now, 20 years from now. Still understanding. Opening snap means I'm popping a valve open during diastole. I said if you're forcing it open, it's got to be stenotic. That means only two choices, tricuspid and mitral valve stenosis. Kathia. Tricuspid and mitral valve stenosis. You understand that? Kathy! Do you recognize that one's on the right side? One's on the left side? Kathy. Later on, you got to separate them for me. Cammy, do you understand? When you hear an opening snap, what do you think of? Stenosis of what? That means you're trying to pop a valve open during diastole. Do you understand it, January? Opening snap. Ejection click. Michelle. Means you're trying to pop a valve open during systole. During systole, what's going on? Ventricle is contracting. What part of EKG picks that up? That's depolarization. I want to contract the ventricle right now. The ST segment. All right, so ejection click means I'm popping a valve open during systole. Nicole, if I'm popping a valve open, is that valve stenotic or regurgitant? What was that? It must be stenotic. Linda, if you hear an ejection click, what do you think about? Stenosis of what? Aortic or pulmonary valve stenosis. Does everybody understand? So that means, Linda, if you heard an opening snap, what do you think of? Now, you got to remind yourself what it means. So you guys, you're trying to remember that other slide. See what happens? If you just try to go back to that slide and try to memorize, it means you forgot what it means. Opening snap means you're trying to force a valve open during diastole. What two valves are trying to open during diastole? Tricuspid and if you're trying to force them open, are they stenotic or regurgitant? That's how you recreate your list, which means the top two causes are stenosis of tricuspid mitral valve. Do you understand now, Linda? We're going to recreate information. We're not going to just memorize. You understand, Andre? If you heard an ejection click, finish. Stenosis of the aortic and pulmonary valve. Hey, Kathia. Do you see? One's on the right. One's on the left. You got to separate them for me sooner or later. If you heard a mid-systolic click, Al. Well, I already give you your answer. Mitral valve prolapse. Now, let me illustrate what mitral valve prolapse means. Let's say the valves are supposed to be closed like this, right? Left ventricle down here, so that when the ventricle contracts, the valve is supposed to stay nice and tight so that blood rolls off of it out of the aorta like this. The mitral valve is on an angle like that, okay? Left ventricle down here, boom, blood, yeah, that way. Everybody with me so far? Whenever you have mitral valve prolapse, let me just straighten out the valve so you can see it. When the blood hits the valve, beep, buckle, that's the prolapse. See that? It pushes up into the left atrium, but it does not regurge. There's the difference. Everybody understand? I want you to visualize prolapse versus regurge. So when they say mitral valve prolapse, you just hear the mitral valve buckling and then pops back down. So that's why it's going to happen in the middle of systole. Why? Because when the left ventricle contracts, there's a little time gap before that blood hits the mitral valve. See? Mid-systolic click. And that's how I can make the whole term visual. So I don't have to memorize what it goes with. I can see it the minute you write this on any test question. Mid-systolic click, I say mitral valve prolapse. 7% of women have it, folks. You will hear it. Well, it turns out, Nelson, if you have less volume in the ventricle has to contract harder. Does that make sense to you? Which means it's going to prolapse quicker. That's why it moves closer to S1. And if you got a lot of volume in here, then the ventricle can't contract fast anymore. That's why it's going to prolapse later. That's why it moves closer to S2. Ought to lead. That means if I can do anything to decrease the volume in your left ventricle, your mitral valve will prolapse faster. Do you understand me? Do you understand why, Kathy? Do you understand why, Nicole? You understand why, Kathy? Explain it to me again. So it contracts faster. Everybody understand that physiology? So that means, Tina, how do I decrease the volume in your left ventricle right now if I asked you to? Because if I can get you to decrease the volume in your left ventricle right now, I can tell you mitral valve will prolapse faster. Yeah, I want to decrease the volume in your left ventricle. Not Melanie's, just yours. So how do yours? That's decreasing end systolic volume. I want to decrease the volume coming into the left ventricle. That means before it contracts, I want it to contract fast. How do I decrease the volume in your left ventricle? Right now. Right now. Melanie, how would you decrease the volume in your right ventricle right now? Or in your left ventricle? Yeah. No, I want to decrease what's in your left ventricle. January. I want to decrease the volume in your ventricle. Linda, how do you decrease the volume in your left ventricle right now? No, that'll increase it. You're going the opposite direction. All right, Beanish. No. Her answer was inspiration. I said, no, you're going the opposite direction. She said, oh, it must be expiration. That's not what I want either. I want to decrease the volume in your left ventricle. Beanish, how do you do that? All you got to do is stand up. We've been doing it for days now, but you guys seem to have forgotten. All you got to do is stand up. Blood pools to your feet. Mitral valve prolapse faster. That means when that woman comes into your office and you hear the mid-systolic click, all you do is just say, Ms. Johnson, can you rise to your feet for a second? And then you hear that prolapse happen faster. All right, go ahead and sit back down. See that? Oh, folks. See, whereas you read the article, what's that telling you? Oh, do an echocardiogram. What the heck? You want to spend $500 to do this for? $500 to just do this? That means we as physicians are not even doing our job. We've got to be doing echocardiogram for everything. Folks, you're going to learn how to figure out and diagnose almost any heart disease this afternoon. This afternoon. Yeah. All right. Here we go to S1. Back to you, Linda. What makes the sound of an S1? Closure of the mitral and tricuspid valve. Sounds so much nicer when she says it. Mitral and tricuspid valve. Look at it turning red over there. Okay. So anyway, so S1 is closure of mitral and tricuspid valve. Which valve closes first, Linda? Huh? How do you know? Stop that. No changing answers around here. We don't allow that. Of course, it's mitral. Just prove yourself right. But don't, when I hesitate, it doesn't mean that you're wrong. I just want to hear your explanation. Dead left. Well, how do you know it's the left side? Right. I said you were correct. All I did was just stall for a second. You were ready to switch. All right, survival technique number, whatever we're on. Whenever you're on teaching rounds, attendings love to do this. They like to stare you down. Just so you know, they stare you down to see if you actually know what you're talking about. If you give an answer, stand firm, folks. I always tell them, put your cleats in the ground and stand there. If you say mitral, you stay with mitral. Doesn't matter if I look at you real hard. Doesn't mean if this eye starts wandering over here. You stand there and you stay as mitral, Dr. Francis. And if the attendant says, what? You say mitral. Say it again. The reason is you're going to be right more than 90% of the time. Remember, you're learning it now, okay? You're going to be right more than 90%. But if you change your answer, you just showed him you were guessing, that you don't know what you're talking about again. In his mind, even if you're right, you get 0 points again. Folks, don't steal points away from yourself. That guy's got to grade you. I mean, fortunately here at the program, I don't care how many wrong answers you give me. I'm going to show you how to be right. But that guy's going to be grading you. So that means if you take away your points when you are right, and you already know when you're nervous, you're more likely to be wrong, that's all he remembers, all the times you were wrong. That's not the impression you want to give him. Okay? You don't want to know it and still be picking the wrong answers. All right, same thing on the test. You don't want to know it and be picking the wrong ones. All right, so if you got an S1 made by mitral and tricuspid, I got a soft S1, Linda. That means one of those valves is not closing. Two guys make a sound and it's softer, somebody's not making it. You understand? What do you call a valve that's not closing? Regurgitant or stenotic? What kind of valve does not close? Regurgitant or stenotic? Has to be regurgitant. Does everybody agree with Linda? Because that's the correct answer. There it is. That means you either have mitral regurg, tricuspid regurg, or maybe you don't have a valve. A valve that's not there can't close, right? So for the Boris 2 people, that'd be tricuspid atresia. But that one is simple, because that baby is born blue. See, that one's easy. But mitral tricuspid regurg, well, you don't know yet. But if you give me a baby who's blue, shit, the valve's not there. That's why he's blue. Blood can't even get out of the right atrium. Does everybody understand that? Make sense, Dan? Make sense, Rashmi? Yeah, makes sense. Pinesh? Malika? Yeah. All right, so soft S1, tricuspid mitral regurg. Or the valve is not there. Tricuspid atresia, mitral atresia, but those babies are cyanotic. Everybody agree with me so far? All right, that's a soft S1. What about if you got a loud S1? If I got a loud S1, Nelson, then it means one of your valves is banging shut. Do you understand that? Then that means either you got a stenotic valve that does not want to open, because you got a stiff valve, boom. Everybody follow? Boom. It's like one of those rear doors that's on a spring. As soon as you try to, bang, your mom starts screaming at you for making the door bang like that. All right? Spring, boom. Keeps banging down real hard. So if you say you got a loud S1, I say either you got a stenotic mitral tricuspid valve, everybody follow? Or you got a high pressure in front of it. Now let me illustrate. If you're up here, mitral tricuspid valve, they open down into the ventricles like that. Okay? So if I got valves that open down into the ventricle, when the ventricle is contracting, part of what closes it is like that. See that? Contraction, contraction, contraction. That means either you got a stenotic mitral tricuspid valve, or there's high pressure in that ventricle, so that when it contracts, boom, it really pushes that thing closed. You understand, Kathy? If you truly understand, Kathy, tell me something that'll give you a loud S1. Give me anything that'll cause a loud S1 that you know of. What? Not a loud S1. All right? Or the lead, give me a loud S1. Let me just again repeat. What makes a sound a loud S1? You got a stenotic mitral tricuspid valve, or you got high pressure in one of the two ventricles. One with a loud S1 doesn't have either one of them. They actually have decreased conductivity. That's all you'll see in a second. Oh, the lead. Give me something that'll give you a loud S1. All right, Kimberly, loud S1. All you got to do, mitral tricuspid stenosis or make the ventricle contract harder. Any one of those three will give you a loud S1, folks. Duplicate it any way you want. Peggy, loud S1. What? Anemia. Sapanta. Loudest one. Like what? Hypertrophy due to anything. Sakchite. Loudest one. Thick ventricle due to what? High pressure due to what? Hypertension sounds good. Why did you get hypertension? Just give them a reason. All right? Hypertension due to too much volume. So B, give me a loudest one. Fibrosis. What drug is he on? What? Adriamycin. Dahlia. Loudest one. All right, rheumatic fever. You got stiff valves. That leads to mitral or tricuspid stenosis. Joseph. Loudest one. All right, Frank, loudest one. Okay, exercise. Epinephrine and norepinephrine. Nita, loudest one. Oh, you're sitting too close to me, stealing your answers now. That's all right. Nita knows another one. So, Nita, give me another one. Who says beer? Do you agree? What'd you say? Fear or beer? Or fear of beer? Which one? I don't know. You said fear? All right. All right. Remember I told you that survival technique? If the attending ever says right to anything someone says, I told you all you had to duplicate it again. Now, if you know the physiology exercise is just epinephrine and norepinephrine, well, fear does the same thing. You know, pheochromocytoma does the same thing. Hyperthyroidism does the same thing. I go on and on. And the attending has no idea what I'm doing. All he knows is I'm right about everything I tell him. He said right to one guy. That's it. I'm ready. All right? That's what you got to do. All right, Diana, give me a loudest one. Anything you can think of that gives you a loudest one. Right ventricular hypertrophy. Diana, do you see the physio that I see? Do you see it with me? Do you see how to do it now? Now, loudest one, what we do? Just went around, come up with 10 or 15 things, right? Now, look how much simpler that was. I told you. National survey. For students, 2 things. For residents, 4 things. I told you, nobody's using physio to think. Everybody's just trying to remember what they read out of some book. Okay? So, loudest one. You talk it out. So let's say Dr. Johnson asks you, what's your differential for a loudest one? Well, from what I read, Dr. Johnson, my understanding of a loudest one, first of all, an S1 is made by the closure of mitral and tricuspid valve. So if I have a loudest one, then that means either you got a stiff mitral tricuspid valve, i.e. stenosis, or there's high pressure in front of it, because when the ventricle contracts, it closes it. Everybody follow? And then I say, well, cause of mitral stenosis would be, cause of tricuspid stenosis would be, things that make the ventricle contract harder would be. That means if you want drugs, dopamine, dobutamine, digitalis, all the beta agonists, we can go on and on, turn it into 50 things before you finally says, okay, stop. Okay, you understand it. Oh, man, I used to get it, boy. I wanted to high-five Dr. Shaw every time I did that to an attending, man. Oh, I just loved it. Because remember, these are the same guys that heard I was on probation. And all of a sudden, now here I come. I was like, ask me anything. Ask me anything. Oh, man, I loved it. All right, so that's what I'm sharing with you. This is how you do it. So, loudest one, anything that makes the ventricle contract harder. Now, you heard all those. What if I asked you what effect does Snickers bar have on your heart sound? Your book never told you. First aid never told you. A Snickers bar will have what effect on your heart sound? Well, I say, well, a Snickers bar, chocolate, has methylxanthines. Methylxanthines works just like caffeine or theophylline. Block phosphodiesterase, increase cyclic AMP. Isn't that sympathetic? Increase contractility. Loudest one. Boom, boom, boom. Y'all better get off me, boy. Y'all better get off me, man. Come on, baby. The attorney never thought you'd come up with that one. Okay? See, that's the thing. You don't know how they're going to ask the question. They're asking them in ways, folks, they know your book never told you. To say a Snickers bar, students panic right away. What the heck is Snickers bar doing on my exam? Where'd they get that question from? I hear that all the time. They got it from the same book you read. They just put a new context for you. All right, so loud S1, the first thing I think about, Linda, either you got a mitral tricuspid valve stenosis, right? If you have a mitral tricuspid valve stenosis, what are you going to hear on exam? Ejection click or opening snap? Opening snaps. If I hear an opening snap, I know it's one of those two. If I don't hear an opening snap, the ventricle is contracting harder. That's how you start to separate it out, folks. Man, Dr. Shaw used to go in 20 seconds, he could tell you what heart disease the patient had. I said, how did you do that? And he had like 4 or 5 of us. We couldn't figure it out. This is exactly what he knew. He knew how to just systematically figure it out. So you get a loud S1. Then his mind says it could be mitral tricuspid stenosis. He listens for opening snap. If opening snap, it's one of those two. If no, it's the other one. The ventricle is contracting harder. Now you got to figure out why it's contracting so hard. Everybody with me so far? All right. Loud S1. What about an S2? S2 is made by closure of aortic and pulmonary, right, Michelle? Which one's going to close first? The aortic. Why? More pressure and resistance, she says. She's all over it. So if I got a soft S2, 10 V, soft S2 means one of those valves is not closing. What do you call a valve that's not closing? Regurgitant or stenotic? Regurgitant. Pulmonary regurg, aortic regurg. Or maybe one of those valves is not even there. Pulmonary and aortic atresia. Everybody see the pattern here? Just like we did a soft S1, now we're doing a soft S2. This is how you recreate your knowledge so you don't have to memorize lists. There's a way to just recreate anytime you want. Soft S2. Now, the pulmonary aortic atresia are easy because those babies are blue when they are born. How can you be pink if blood can't enter your aorta? I mean in the lungs, and blood can't leave the aorta. You're not going to be pink. Forget it. You understand, Paul? All right, so that's the soft S2. Finish. I got a loud S2. If I got a loud S2, here it is again. Either you got a stenotic, aortic, or pulmonary valve opening up into the aorta, over here, into the pulmonary, right? Or you have high pressure in front of it. Now remember, the aortic and pulmonary valve open up like this. Remember the other two I just told you open down. All right, so if they open up, that means there's high pressure in the aorta, over here in the pulmonary. You understand? Anytime you hear a loud S2. Tamir, make your S2 loud, man. Any way you want. You got to understand what a loud S2 means now. Don't let the mind start guessing. Do you understand the physiology of a loud S2? Aortic stenosis or pulmonary stenosis or high pressure in the aorta pulmonary. That's it. Because the valve's trying to open and the pressure pulls it right back down. Duplicating, my son. Go to work. I don't care what you use. Just make sure your answer matches what you just told me. Exercise will do it. Tara, go. Turner's coarctation will do it. Come on now. Renal stenosis will do it through hypertension. Linda, go. No, Linda, go. Yeah, one of 3 things to duplicate. I don't care how you do it. All you got to do is think of the 3 things and find a way to duplicate one of those 3 things. Either aortic or pulmonary stenosis, or you got high pressure in the pulmonary or aorta itself. Cor pulmonale will do it, Andre. Excitement will do it, like he's feeling right now. Yeah, Basil. I'm thinking when you sit down from standing position. Okay, yeah, that'll cause compression of the vessels. All right, Rebecca. Caffeine will do it. Paul. Pulmonary edema will do it. Come on, Malika. Pulmonary embolism will do it. Finish. Snickers bar will do it too. All right, so now look how easy it is to come up with our differential. Now, loud S2. If it's due to aortic or pulmonary stenosis, finish. Are you going to hear an opening snap or ejection click? And if you hear an ejection click like she says, then I know it's pulmonary or aortic stenosis. If I don't hear an ejection click, finish, then I know you got high pressure in the pulmonary or aortic, aorta itself. Everybody understand that? Now let me show you how to figure out the sequence of events. Tim, If I got a coarctation of the aorta, is that going to affect your right or left side? The left side. So is it going to affect the aorta, aortic valve, or pulmonary valve opening? Aortic valve opening. Is that going to create increase or decrease resistance for the aorta? Increase. Is the valve going to close harder or softer? Harder. So what effect will it have on S2? Make it louder or softer? He says louder. Is this a resistance or volume problem? If it's a resistance problem, do muscles hypertrophy or dilate? Hypertrophy of the left ventricle, will it contract harder or softer now? What'd you say? I said if the left ventricle hypertrophies, like you said, will it contract harder or softer? No, hypertrophy. That's more contractility. Yeah, that's what I just said. What did you say? See what you guys do? You switch the answer. I just gave a talk about it. I said, stop doing that. And you go 5 minutes later, do the same thing. Okay? You stick to your guns, man. I told you. The attendings do that all the time. All right, so the left ventricle contracts harder. If the ventricle contracts harder, Tim, will you get a louder or softer S1? Louder. So does everybody see? Given any problem, you can take me through the sequence of events. It's going to affect both heart sounds. It's just a question of which one affects first or second. Everybody understand that? Now, on the boards, which one do you pick? Because they're going to affect both of them. You always pick the one that affects first. I'm just letting you know that. That's going to be over 90% accurate. Every now and then there's some test writer who wants the later one. I'm not guessing. I'm picking the first one every time, okay? Which means I'll be right 90 to 95% of the time. And a few times he wants the second one, I'll just be wrong, okay? Remember, play the odds. So that means if I got coarctation eros, is that going to affect your S1 or S2? S2 will be affected. Will it be louder or softer? It'll be louder. Is this going to create a resistance or volume problem? Resistance problem leads to hypertrophy or dilation. Hypertrophy of the left ventricle contracts it harder or softer? Harder, which leads to a louder or soft S1. You the man. You the man. That's how it's done. That's how it's done, folks. Look at that. We can figure out the cardiac manifestations for anything right now without guessing. As long as you don't start guessing now, follow the physio. That's just S1 and S2. Any questions so far? Yes, sir.
How do we distinguish between opening snap and a loud S1 or an opening ejection?
No, they sound different. They sound differently. Yeah, ejection click is totally different from the S1, which is totally different from the S2. It depends on where they occur. You know, boom, boom, and the ejection click happens right here in the middle. Yeah, it's the timing of it. All right, so loud S2. Everybody clear about that? Excuse me? Yes. Correct? Right. You would have a loud S2. Why? Because the right ventricle now has to contract harder against the pulmonary hypertension. That means if they ask you to explain things, Bartlett, you can also explain it. Once you understand the pieces to it. Everybody understand? The remark he made was pulmonary fibrosis, like bleomycin busulfan. How would it affect a loud S1 or a loud S2? Well, here, primarily, it's going to be a loud S2 because you cause it pulmonary fibrosis. That means the right ventricle is trying to pump against it, and the valve, boom, keeps shutting back down again. Okay? Any questions on S1 and S2? Melanie? If you have congestive heart failure, what is it? It's a volume problem. You would hear what? Yeah. Why a loud S2? Right. Why do you have high pressure in front of the valve? Now, fluid overload doesn't give you high pressure in front of the valve. The fluid overload is in the ventricle. So you got to know whether your first aid is right or wrong now. You got to know that physio. And they say loud S2 is because you already have high TPR from low volume state. Yeah, that's my point. All right, so anyway, loud S1, loud S2. Any questions on that? What causes S2 splitting? Kathia. S2 splitting, listen carefully. S2 splitting occurs when you breathe in. S2 splitting occurs when you breathe in. Why? Because when you breathe in, Kathia, you bring in oxygen. Oxygen, as you learn in vascular physiology, is the most potent pulmonary vasodilator. That means if you dilate the pulmonary vessels, what happens to pulmonary resistance? Decreases, what happens to pulmonary vascular pressure? Decreases, so what happens to pulmonary blood flow? Increases. So if you increase the pulmonary blood flow, you have to keep the pulmonary valve open longer to let that volume get into the lungs. So when you have wide S2 splitting, it's really the pulmonary valve that's staying open longer, and therefore, boom, closes later. That's why now your ear can detect two sounds like that. Okay? So S2 splitting, therefore, Tamir, before I answer your question, I can break it down into three physiologies. 3 pieces of physiology. That's it. No test writer can change it. Do you understand? S2 splitting equals, folks, number 1, give me more oxygen. Number 2, increase the volume in my right ventricle, so the valve has to stay open longer. Or number 3, delay the opening of the pulmonary valve, which means you delay the closure of it. S2 splitting, 3 reasons, no more. Tamir, you had a question.
Yes. What does it mean, bangs shut when it tries to open?
Because it's so stiff.
Right.
Which means every time you try to open it, the fibrotic fibers pull it right back down. Yeah. Stiff valve, bangs shut. So S2 splitting. Melanie, do you understand? We broke it down into 3 pieces of physiology. What are they again? Give him more oxygen. Increase the volume in the right ventricle. And delay pulmonary valve opening, and therefore the closure. Cammie, make your S2 splitting wide any way you want. You can drink a liter of water. More volume in the right ventricle. Leslie, make your S2 split wider. Breathe in. Oxygen. Eros, make your S2 split wider.
Higher altitude,
High altitude has less oxygen.
but you gotta breathe more.
Doesn't matter. You still have less oxygen. You just went against one of the 3 features. Now, when you climb back down the mountain,
Climbing down the mountain.
there you go. That's what I thought he meant. That's what I meant. Yeah, that's right. So when you go up to the mountain and then you climb back down, then it's split wider. PJ, S2 split wider. ASD, left to right shot. Dinah, make your S2 split wider. Now remember, you got 3 physiology to duplicate. Don't let the mind just guess. All you got to do is duplicate one of these 3 physios. Oxygen, volume in the right ventricle, delay the opening of the pulmonary valve. Do it any way you want. Let's try B-niche first. We'll come back. Make your S2 split wider. Give him oxygen, Malika. Pregnancy has more volume. Come on, Paul. Keep it rolling, man. Pulmonary stenosis, delayed opening, so delayed closure. All right, Rebecca. Make S2 splitting wider. Now you got to give more oxygen. Remember I said 3 things to duplicate. Give them, you increase the oxygen, volume in the right ventricle, or delayed opening of the pulmonary valve. That's the only 3 things you can duplicate. If you go in the opposite direction, S2 splitting will narrow. That means if you take away the oxygen, take away the volume, or to make the pulmonary valve close faster, you will narrow the S2 splitting. I want to make it wider. Put in more oxygen. Even more than B-niche did, huh? We're just going to intoxicate the hell out of them. Just so we can make that S2 split real wide. Give them 10 liters. Who cares? All right, Faisal. Oh, no, that's not going to cause it. You got 3 things to duplicate, Faisal. Pulmonary fibrosis makes you hypoxic. You just took away one of them. That's narrow. Andre will do it for you. Binge drinking. Not that he's been binge drinking, huh? But he heard his friends tell him all about it. No, but that's correct. Very good. Volume. Finish. Redeem thyself, my child. Go ahead. Make him squat. Whenever you squat, you push fluid up to your head real fast. It only lasts for 2 seconds, but you're correct. All right? Diana's got one now. When you exercise, why is that? Diana, what's your last name? Say, I am Dr. Thompson. Raise your hand up in there and just wave like you just don't care. Say, she's seeing physio, baby. That's what I'm talking about. Ooh, I can tell the day when a student finally makes that change. All of a sudden, they're seeing physio. When you can put something together and you clearly illustrate what I just explained to you, that's how I know you can see it. Versus you're trying to remember something way back. Of course, when you've been exercising, you're hypoxic, right? So when you're cooling down, your PO2 goes back up. Guess what? S2 splitting gets wider. S2 splitting. So that means. That's right. Like what? That's right. So give me another one. Okay. Like another one. That's all right, Marcella. That you're correct. Anything that increases the volume of the right ventricle. That's why I told you. Oxygen, volume of the right ventricle. I don't care how you want to do it. You see? That's the part that no test writer can change. There's only 3 ways to do it. So that means, Diana, since you see the physio like I see the physio, tell me, this, when you breathe in, where's there more blood flow? On the right side of the heart or the left side of the heart? When you breathe in, on the right side, Kathy Valdez, do you hear what that girl is telling you? That when you breathe in, there's more blood flow on one side of the heart. On the right side, that means when you breathe out, there's more blood flow on one side of the heart. On the left side. You ever wonder why the doctor says take a deep breath in and hold it for a second? He wants to amplify everything on the right side. You ever wonder why the doctor says, hey, why don't you exhale and hold it for a second? He wants to amplify everything on the left side. Y'all better give me some room up in here. Give me some room. Here it comes. Here it comes. Linda! I got an opening snap on a patient. What's that mean again? Opening snap. Mitral stenosis or tricuspid stenosis, but it gets louder when they breathe in. What side am I on? It's louder when you breathe in. What side is it on? On the right side. So what's the diagnosis? You only gave me 2 things. Tricuspid stenosis. Finish! You got an ejection click. What are 2 things? Aortic stenosis or pulmonary stenosis, but it gets louder when you breathe out. What side are we on? Thank you. 1 hour left. I told you they're going to be talking like cardiologists by the time I get done. Here it comes, baby. There it is, man. If you got a mitral valve problem, all you got to do is roll the patient slightly to the left axilla. That's how you amplify all mitral valve problems. So that means if you want to amplify anything on the right, inhale. If you want to amplify anything on the left, exhale. Folks, that's the most common clue they give you on every board's question. Any sound that happens, you better decide if it's on the right or left before you look down at your answers, or else you're going to accidentally pick the wrong side. Because opening snap, tricuspid mitral stenosis, I got to know what side it's coming from. All you do is ask the patient to inhale. Let's say it's a baby, though. Baby just screaming and crying. Crying, making all kinds of noise, Sunday. So I can't take it no more, baby, shut up. You say, I'm a pediatrician. These babies make so much noise I can't hear anything. I remember about 4 of us, residents, were going in to see a child, and we hear a little murmur, and we all trying to figure out what it is. Hey, what you think it was? It sounded like a PDA, man. No, that was mitral regurg. No, I think that was probably VSD or something. Oh, man, let's get Dr. Shaw. Let him figure it out. Dr. Shaw come in there, put a stethoscope on the child. And he kind of mapped it out just so his eyes kind of move around. What he did was listen to what he heard. So let's say he heard an opening snap. He says, well, it could be mitral stenosis or tricuspid stenosis. He would just wait for the baby to inhale one time. He said, well, how are you going to hear the baby inhale when he's crying? Folks, when the baby's crying or when you're crying, you know what you're doing? Exhaling. You just wait. I'm done. You see that? He would just wait for the baby to cry until the baby takes that one inhalation, that big inhalation, gets louder. He knows it's on the right side. And he walk out. Oh, that's just tricuspid nose. But you guys can do echocardiogram if you want. Every doggone time we did an echo, and it was exactly what he said it was. I said, dang it, man. I want to be like him. I want to be like him. Man, now this was before I got in trouble, and actually, finally, he taught me how he did it. All right, so that's S2 splitting. Everybody cool with that? So we got S1, loud and soft, S2, loud and soft. Now we know how to split S2 or narrow it. So if you got bleomycin, narrow wide S2. Dia. No, pulmonary fibrosis is not the same thing as stenosis of a valve now. It's pulmonary fibrosis. So what effect will it have on S2 splitting? Widen or narrow it? Widen or narrow it, Dia. Give me your first thought. Yeah, I can tell by your eyes are bouncing. It's going to the second one. What's your first thought? It's going to narrow it. Pulmonary fibrosis causes hypoxia. Yeah. Remember, increased oxygen, increased volume in the right ventricle, or delay the opening of the pulmonary valve wider. Anything that goes against one of those three, narrow. Tina! What effect will a PE have? Wide or narrow? PE, pulmonary embolism. What effect will it have on S2 splitting? Wide or narrow? Narrow it. Everybody following? Okay. Pulmonary embolism. A clot in your lungs. Wouldn't it make your PO2 drop? Wouldn't a clot in your lung make your oxygen drop? Well, you just went against one of the three things. That's a narrow S2 splitting. So, Frank, you got pulmonary edema. Wide or narrow S2 splitting? No. If I flood your lungs with water, what's going to happen to your PO2, Frank? But you only got three things to think about, Frank. That's what I'm telling you. Huh? No. If you want to make S2 split wider or narrow, Frank, three things to think about. That means no matter what they tell you on an exam, you say, how does it relate to one of these three things? That's what I mean by it. These are three things no test provider can change. If you start thinking about just the diagnosis, you're going to start forgetting how to make S2 split wider or narrow. Increase oxygen, increase the volume of the right ventricle, or delay the opening of the pulmonary valve. A pulmonary embolism takes away your oxygen. You're going to narrow your S2 splitting. Pulmonary edema takes away your oxygen. You're going to have narrow S2 splitting. Check it out for yourself. Pull out any book you want. That's what I'm saying. If you start thinking about the volume, you think about the volume that came into the lung. Notice how you changed my question. Came into the lung. I'm asking you what's going to happen to S2 splitting right now. Okay? You won't have that much volume coming into the lungs if you're already flooded. You see? S2 splitting is based on how much volume is coming into the lungs right now. If you got pulmonary edema, less will come in. Okay? That's why you have JVD and your ankles are swollen. It's all backing up. It can't go into the lungs anymore. Yeah, but the right ventricle can't pump it into the lungs. The lungs are already flooded. So it doesn't matter if the right ventricle has extra volume. It's the volume that goes across the valve. Remember? I said it's the volume going across the valve that makes it close later. Manny. Well, the COPD is going to be narrow when they become hypoxic. Until they become hypoxic, it'll still be normal. Yeah. You understand, Jessica? You understand, Peggy? Understand, James? All right, S2 splitting, complete. So let's say you got chronic lupus of the lung. Miguel, wide or narrow S2 splitting? Why narrow? Because you're hypoxic. Why are you hypoxic? How do you know somebody with lupus lung disease is hypoxic? Chronic lupus lung. How do you know they're hypoxic? Your answer is correct, Miguel. Just prove your physio. That's all I'm saying. I want you to see it now and forevermore. Why is it chronic lupus of the lung? We'll give you narrow S2 splitting. Leslie will explain it to you. You got fibrosis. End of story. Chronic anything. Fibrosis, Miguel. That's what I'm saying. If you listen carefully, the clue is in the question, man. The test writer almost always gives away the clue to the answer. That's only if you know the language. Tony. What? Lupus of chronic lupus of the lung. It's going to give you pulmonary fibrosis, at least a hypoxia. Yeah, you can do it either way. It's still going to lead to hypoxia and pulmonary hypertension. Tony.
Do you have a disease that's going to decrease oxygen saturation, but at the same time the lungs are able to constrict? Is it going to increase resistance and delay the opening of the valve?
No, it's just going to be delayed opening of the valve, but less volume can come across. So the valve will still close fast with pressure trying to close. His question was, if you have high resistance in the pulmonary, doesn't that delay the opening of the pulmonary valve? It does, but it's going to close it so fast, S2 splitting can't even widen. Yeah. So that's S2. On to the next one. S3, as defined in your books. As defined in your books. It says, Sandeep, S3 is a sound made by a non-compliant ventricle. Do you understand what I just said? S3 is a sound made by a non-compliant ventricle. That's what your books say. Do you understand that, Sandeep? Well, it was on a Saturday morning, and I was reading my books in the library. This is after I met Dr. Shah. That man made me so excited about learning. I was in the library on a Saturday morning reading my books. S3 is the sound made by the non-compliant ventricle. That's what I read. I said, I don't know what that means. What does a non-compliant ventricle mean? I said, the only concept of non-compliance I have is somebody who doesn't take their medication like the doctor said. So I'm trying to think which medication did the left ventricle take. I couldn't get it. And then I happened to be reading a chapter on dilated hearts. And all of a sudden I noticed by the third disease, that one had an S3 as well. I said, wait a minute. Turn back to the other two. They had S3. I said, hang on. I started flipping through the whole chapter. Every disease had an S3 in there. I said, oh my God, wait a minute. I think I know what an S3 is. The synonyms, three things. S3 means one of three things, folks. So their definition, it says non-compliant ventricle. Dr. Francis said, no, it means one of three things. This is the part I like because I can visualize these three things. If you got a volume overload, I'm branding you an S3. If you got a dilated ventricle, why? Because remember Frank Starling? If the EDV keeps going up, you see that? You're dilating the ventricle. So volume overload, dilated ventricle. And when you're stretching out muscle fiber, you lose your cross bridges. See that? You lose contractility, so you decompensate. So S3 is a sound made by non-compliant ventricle, but I think of it as three things. Volume overload, dilated ventricle, decompensation. So I said, Jenny, everything I could think of that had a dilated ventricle or volume overload, I turned to in the Book of Robbins, and I'll be doggone if every one of them didn't have an S3. I said, whoa, I think I know what an S3 really is now. Also, I got a picture of it. Here's normal. Remember, we always started with normal. Right hand's the left ventricle. Aortic valve is right above it like this. Mitral valve is on an angle like this. So you got aortic valve and then the mitral valve on an angle like that. So aortic valve opens like that, mitral valve opens down like that. Everybody follow me? All right, so I'm here in the left ventricle. So mitral valve will open, blood rolls in. Left ventricle starts contracting, S1. Then the ventricle keeps contracting. That's isovolumetric contraction. Then move over here to aortic valve. Aortic valve opens. Sustained contraction. And they can't hold it. S2. And then isovolumetric relaxation. As the pressure in the left ventricle drops below that of the mitral valve or left atrium, the mitral valve opens up again and blood rolls quietly into the left ventricle. That's normal. What about if you got a dilated heart? A dilated heart does not come way up here. It does this. See that? You lose that contractility. That's the non-compliant. You lose the contractility, so that means the ventricle only does that. Now the blood, aortic valve opens like this. Blood, a little bit go out. That's why you have decreased ejection fraction and cardiac output. Then when the valve closes, and the mitral valve opens, blood comes into the left ventricle, and the left ventricle is still way down here. That's why it drops into it and makes a splash. See that? That's why it happens right after those valves open. That's why if you look at another book, they talk about early filling sound. What they mean is, as soon as the tricuspid mitral valve open, you hear a splash. You should never hear a splash in a normal person. I shouldn't be hearing blood come from the left atrium and splash into the right atrium. I mean the left ventricle. Or from the right atrium and splash into the right ventricle. Unless that ventricle never contracted way up to the valve like it should have. Everybody understand that? That's what all this noncompliance is about. But that's why I want you to think of it as three things, folks. Volume overload, dilated ventricle, decompensation. S3. Well, I was med-peds. That was internal medicine book. So I turned my pediatric book. And it said, S3 is a normal finding only in adolescent female. I said, wait a minute. If I understand the concept, the answer should not be wrong. What do you mean an adolescent female has an S3 and it's normal? I said, I wonder what an adolescent female's heart beats like. I go right next door, audiovisual lab. Wouldn't you know they had a tape on how the adolescent female beats. I said, ooh, thank you. Here's how it beats, folks. The left ventricle, when it beats, an adolescent female does this. See that? Dilates with every beat. In an adolescent female, dilates with every beat. And then by the time she's about somewhere between 18 and 23, it beats like that, like that, like that, like that. I said, oh my God. That means I do understand it. S3, the concept has not changed. Then I thought to myself, I said, self? He said, what? I said, self. How come an adolescent male doesn't have it? And I said to myself, Al, self? He said, what? I said, self. What is it that an adolescent female has that an adolescent male does not have? Al, help me out. Some of them got gynecomastia, Al. It's okay. So, he says estrogen. And that adolescent female has estrogen. You understand, Cammie? You understand, PJ? You understand, Rashmi? You understand, Maria? That an adolescent female has estrogen, and that adolescent male doesn't have it. That's why the female goes through that, but the male doesn't. I said, wait a minute. I think I understand this concept very well now. That means, Tina, that means, Tamir, that estrogen is a muscle relaxant. That's the only way. The ventricle will dilate like this until she has normal cycles, and then the progesterone balances it and goes back to this. That means, Tina, that estrogen is a muscle relaxant. You understand what I just said, Tina? You understand what I just said, Tamir? Benish, you understand what I said? If I'm right, Benish, tell me what I got to do. I got to break it down one time for you and tell you why the muscle mass for a female has less tone in it than that of a male. Sounds like muscle relaxation to me. That's why women have more reflux than men. Sounds like muscle relaxation to me. That's why women's blood pressure is lower than men. That sounds like relaxation to me. That's why women get more UTIs than men. Sounds like bladder relaxation to me. That's why women have more varicose veins than men. Sounds like relaxation to me. That's why women have more hemorrhoids than men. Sounds like relaxation to me. That's why women have more constipation than men. Sounds like relaxation to me. That's why your uterus can stretch way out like that. That's why a woman's hips can stretch way out like that when she's pregnant. Oh, that's why when she has too many babies, all of a sudden the hip never snaps right back. She keeps her big hips now. Folks, check it out, and you will see the estrogen connection. Oh, give me some room up in this joint. Estrogen is nothing but a muscle relaxer. On a Saturday morning, Mustafa, I'm missing my favorite cartoon, man, Hong Kong Phooey. I didn't even get to see my cartoon. But on a Saturday morning, I made a solid connection. The estrogen connection, baby. All of a sudden, I didn't miss out on my cartoon anymore, man. I said, holy cow. I see it right here. Wait a minute, Mustafa. Give me a condition where you see a lot of estrogen, man. Obesity. That's why women who are obese produce too much estrogen. That's why women who are obese all of a sudden have larger uterus. That's why women who are obese have a higher incidence of dysfunction uterine bleeding based on estrogen. How about fibroids? Have more constipation. How about that? Have more UTIs. How about that? How come the pelvic floor falls and therefore all of a sudden you got uterine prolapse and sister seals and rectal seals? Y'all better give me some room up in here. Let me give me some room. Wait a minute, what about a pregnant woman? Isn't she bathing in estrogen? Look it up in a pregnant woman. Why she has an S3. Why she has a dilated ventricle. Why she has varicose veins. Why she has hemorrhoids. Why she has reflux. Why she has constipation. Why she has lower blood pressure when she's pregnant. Check it out. Check it out. Give me some room up in here. Wait a minute. Wait a minute. Hey, wait a minute. Tara, what organ gets rid of estrogen? Kidney or liver? The liver. How do you know that? Is estrogen a protein or steroid hormone? Steroids are fat or water soluble. Fat soluble things go to the liver. Wait a minute, Kathy. That means if your liver can't get rid of it, you're going to be swimming in estrogen, right? Do you understand, Kathy? Do you truly understand? Do you see the physio that I see? Do you see why when you have cirrhosis you get gynecomastia, testicular atrophy, penile atrophy, constipation, reflux, hemorrhoids, varicose veins? Y'all better give me some room up in here. Give me some room, folks. Let me tell you. Why do you think you have, esophageal varices and a cirrhosis? Why do you think you have pulmonary erythema? Oh, see, folks, this is why they fool you. They keep giving it new terms, and you never still see the original connection. That's why you guys write that stuff down. It means nothing to me but estrogen. That's it. That's all it means. That means when a pregnant woman gets that glow that everybody's talking about, you know what that is? Extra blood flow to her face. And everybody's all excited. Oh, you got that glow, babe. Well, hell, if you get a little extra blood flow to your face, you be glowing too. Nobody has estrogen connection. All right, folks, on a Saturday morning, estrogen connection was born. So let me explain it to you. Your next concept to learn. The estrogen connection says that estrogen is a muscle relaxant. That means any disease where you have too much estrogen. That means from being female, being on birth control pills, cirrhosis. Everybody follow me? You're going to end up with all of these problems I'm about to describe to you. And the ones I just described to you. You will have it, I'm telling you. Okay? All right. Estrogen, besides being a muscle relaxant, causes the liver to produce a lot of proteins. Let me show you how we can connect to a lot more things. If you have too many proteins floating around in your blood, Ferdy, one of the tests that can pick that up is a high saturated C-reactive protein. Anytime you have too many proteins floating around in your blood, your saturated will be high or C-reactive protein will be high. You understand, Rebecca? You understand, Fazil? You understand, Andre? Okay. Well, look at some of these proteins and see the clinical application. Therefore, Kathy, some of the proteins come out of the liver. One of them is called lipoproteins. Ever wonder why women have higher triglycerides than men? What if they ask you to explain it? No, you can. Why do you see hyperlipidemia and cirrhosis? Now you can explain it. Why do you get hypertriglyceridemia with birth control pills? Now you can explain it. Why do you get fatty liver when you're pregnant? Now you can explain it. Oh, that's what a concept is, folks. Something that explains 1,000 things I don't have to look up or doubt. It just connects. I know it has to be the right answer. There it is, lipoproteins. Okay? All right. What about another one? Thyroid binding globulin. Your total T4, let's say if you got total T4, it's going to be TBG, because T4 is bound to TBG, plus free T4. So the two together equals total. Which means, with estrogen around, what happens to your total? Manny. Rise, fall, or stay the same? I said what's going to happen to your total T4 if you're on estrogen? Let's try Danielle. It has to increase. Look at the equation, Manny. Total T4 is free and bound. If estrogen raises TBG, the bound form has to be increased. Does everybody understand that? They love to ask you how estrogen is going to change somebody's thyroid profile. You better know this, or else you're going to be working up a lot of females for thyroid disease that doesn't even exist. You know how many women are on birth control pills? What are you going to do now? They're coming with these high numbers, and you say, oh, my gosh, they got hyperthyroidism. No. The key is, as long as they're free is okay, you don't have to do anything. Best measurement of free is called a resin uptake test. Because if you do a resin uptake, it shows that it's low, which means the free is still down there where it's supposed to be. The total is high because it's all bound, TBG. Everybody understand? They'll give you a woman on birth control pills, and 3 months later she comes back and you do a thyroid profile, and they're going to actually explain these things. How about a pregnant woman? Her total will be high too. Everybody understand that? Ah. Let's say, January, I've got you on thyroid replacement. Then I put you on birth control pills. Now you're going to make all this TBG. It's going to bind up so much of the drug I gave you. What's going to happen to your free T3? It'll decrease. That means your advice to your patient while they're on birth control pills is do what to their dose of thyroid? To increase it. That's how they make it a board's 2 or 3 question. But if you don't understand the physio, how are you going to answer it? It becomes guessing again. All right, so you got to know estrogen will raise your TBG. That means you're going to have more that's bound. That means if I'm giving you free, i.e. thyroid replacement, that's going to drop in the plasma. You got to give me more to maintain the normal TSH. All right, January.
What happens to your TSH though?
In whom?
In a pregnancy.
In a pregnant woman, the TSH remains normal. That's how you know she's never hyperthyroid. Just a transient rise in the total. Okay? All right. So that's TBG that comes from estrogen. Everybody understand that? Estrogen connection. All right. Yes.
So you're increasing the thyroid force.
Binding globulin, not the free T3. Correct.
So you're going to bind more of the
Of the free. That's correct.
So you're going to have less free?
Less free. Remember, it's the free that's active. Yeah. Same amount. It's just now the free is less. It's the free that has effects on you, not the bound.
So the total stays the same.
Total. No, the total can rise because you keep making more TBG. As long as you stay on estrogen, your TBG will keep rising. But it's going to outpace the dropping of the free.
So just thyroid binding globulin by itself increases the total.
It will increase the total because the total is the two things together. Okay? The free can drop if you've got the patient on free. So let's take all the situations. Let's say I just give you estrogen. As long as your thyroid is normal, your thyroid will put out extra T3. You follow me? That's why your total will be high, but your free T3 is normal. Do you understand that one so far? Everybody understand that situation? Second situation, a patient who's already hypothyroid, and then I put them on thyroid supplement. So they depend on the free T3 I'm giving them. If you now put them on estrogen, you're going to bind up some of that free T3 that you were giving them with the TBG. So you have to give them more T3 to keep their TSH normal.
So in that case,
The free will drop, correct, which means the TSH will start to rise again.
the total will...
Total will rise because it's mostly TBG. All right, then you need to know that androgens do just the opposite. Androgens destroy TBG. So they'll give you the athlete who's injecting androgens and then ask you why his total T3 is so low. Okay? And you got to explain that one. All right, so that's TBG. What about the next one? Angiotensinogen. Well, Brendan, the estrogen will raise your angiotensinogen. You follow that? Angiotensinogen is inactive as long as it stays in this form. Do you understand that? So let's say you got a pregnant woman. She's got a lot of estrogen, doesn't she? She's going to produce a ton of angiotensinogen. Does that make sense so far to everyone? But because a pregnant woman has so much volume, Al, what happens to her renin levels? Stays low, so you got nobody activating this angiotensinogen. But let's say for any reason, folks, if that baby's placenta suffers ischemia for any reason, the placenta acts just like a kidney. If the kidney sees low flow, what does it secrete? A ton of renin. And now here's a ton of angiotensinogen ready to be activated just like that. Her blood pressure goes through the roof. What do we call that? Preeclampsia. See that? Because that hypertension came on so suddenly, Tim. That's why her kidney wasn't ready for it. That's why you see proteinuria, just like that. Hypertension, proteinuria, what do we call it? Preeclampsia. Oh, but I can see it right here. I can see it right here, folks. You can put a new name on it, but I still see the same physiology. All right, so we call it preeclampsia when you have hypertension and proteinuria. Remember, this is when you have ischemia to the placenta. When is that likely to happen? Third trimester. Why the third trimester? Because the baby's so big and needs so much more blood, and the mom's not giving him enough. That's why preeclampsia almost always occurs in the third trimester. It's a relative ischemia. The baby's just not getting enough. He'll scream out with a ton of running, activate all that angiotensinogen. We call it severe preeclampsia when the systolic blood pressure goes above 160, Matt. Why 160, Matt? We call it severe preeclampsia if the systolic pressure goes above 160. Why are we worried about 160? What's the term for that? No, you're outside of. Outside of autoregulation. Remember, 60 to 160 systolic. That's why we put a new name on it. I told you, concepts don't change. That's why you always got to go back and learn your original concepts. So that when they start changing the names, oh, okay, great. You want to call it that now? That's fine with me. But I'm worried after 160 because maybe the cerebral vessels are not ready. Why do you think intracerebral hemorrhage is the most common cause of death? Right after pregnancy. See? Concepts don't change. Physio doesn't change. Okay? We call it HELLP syndrome, H-E-L-L-P syndrome, which stands for hemolysis, elevated liver enzymes, and low platelets. Well, Diana, we call it HELLP syndrome when you have full-blown vasculitis, Diana. What do you see in a peripheral smear in somebody who's got a vasculitis, Diana? What do you see in a peripheral smear in somebody who has a vasculitis? Schistocytes, torn red cells, and platelets. See that? See, then they get fancy, call it HELLP syndrome. Okay, fine. Help yourself. Okay? But folks, don't get lost in the acronyms that you don't see the physio in there again. Then you'll swear it's something else. Okay? This is just full-blown vasculitis now. That means the whole body's starting to get involved. And then we call it eclampsia when she has seizures. Diana, explain to me how preeclampsia is going to lead to seizures. What is preeclampsia again, Diana? What is preeclampsia? Sandeep, what is preeclampsia? It's hypertension in the third trimester caused by ischemia to the placenta. That's who started this whole thing. All right? Tell me again, therefore, Sandeep, how will hypertension lead to seizures? Okay? How's that going to lead to seizures? Well, let me lead you to the promised land, my child. You want to go to the promised land, Sandeep? All right. Ask yourself, Sandeep, what is the most common cause of a seizure? What is the most common cause of a spontaneous depolarization anywhere in the body? What is it? Ischemia. What happens when you have hypertension? What happens to blood flow, Sandeep? It decreases. Isn't that ischemia? Last I checked. See, I told you when they start changing the names, if you forget the original concept or physio, you'll swear this is something new. Why do you think mama's brain starts depolarizing? Now she got seizures. Why do you think I put a new name on it when it's the brain? Because the brain's the most important organ. But her heart is depolarizing. She's got arrhythmias going too. Her uterus is depolarizing. She's giving birth. She's in labor. Why do you think we give her magnesium? Sound familiar to anybody? Magnesium gets in the way of sodium, and guess what? Seizure stop, arrhythmia stop, uterus stop. Now take her to OR, deliver the baby by C-section. Why are we going to deliver by C-section? Because the baby's the one who started this whole thing. Get that fool out of there. Trying to kill my mama, man. What's the deal here? You see? But this way you understand when they say do a C-section right away, you actually understand why they said it. Because he's the one keeping this going. The man stuff is just to buy you time, but he's going to start activating more angiotensin if you leave him in there. It'll start right back up. That's why they say get the baby out, and then the whole thing will stop. All right, folks, don't forget your concepts. And then finally, look at all the clotting factors that come out now that you've learned about clotting. See that? This is why you have to worry about DVT, PE during pregnancy. Women on birth control pills, DVTs, PE. See that? All the clotting factors are affected, especially fibrinogen, which is factor 1, but not factor 11. So in case they ask you which one is not affected. So that means because we have too many clotting factors around, Maria, after a while they meet up, and then they start forming a clot all on their own. See? Estrogen connection. Powerful stuff, man. Powerful stuff. Well, not to be left out, there's something called an S4, Janice. And S4 is the sound made by an atrial kick. Well, there they go again, Janice. Something about the atrium kicking somebody. I didn't know atrium had legs. Now that it's kicking somebody. Now I'm really lost. What's an atrial kick? Well, S4 is just the opposite of S3. It's a pressure overload, resistance. It's hypertrophy rather than volume. It's compensation rather than decompensation. S4 is opposite to an S3. That means if you got a volume problem, I want to hear you tell me S3. If it's a resistance problem, I better hear an S4. If I say compensation, I want to hear S4. If I say decompensation, I want to hear an S3. If I say volume overload, I say, oh, it's an S3. If I hear resistance overload, I say, oh, okay, S4. Everybody understand here? Here's what makes the sound of S4. Is when the atrium contracts so hard, the two sides actually smack into each other. You hear that? Notice, if we go back here, it's going to happen. The atria contract real hard right before the valves close. See that? That's how I know S4 comes right before an S1 without messing up. You got to understand what it is. Instead of just memorizing what you saw out of a book, it's got to make sense. S1, S2, S3, S4. So that means, let's do one. Linda, stand up. Let's see how tall you are now. Linda, you got coarctation. Stand up. Linda. You got a child with coarctation of the aorta. Linda, stand up. You got a child with coarctation of the aorta. Is that going to affect your S1 or S2 first? S2, because it's in the aorta, right? Aortic sound is at S2. So is it going to make S2 louder or softer? Louder. Everybody following? Everybody should be trying to follow and answer the same questions in their head now. All right, so S2 would be louder. Is this a resistance or volume problem, Linda? Resistance problem leads to hypertrophy or dilation, Linda. Hypertrophy leads to an S3 or an S4, Linda. Would that S4, as she says, get louder when you breathe in or breathe out? We're on the left side. Aorta, don't forget. Aorta, left side. So it's louder when you breathe out. You understand that? All right, so if the left ventricle hypertrophies, and you hear an S4 that goes with it, will that ventricle contract harder or softer? You'll contract harder, making S1 louder or softer? It's going to make it louder. If the left ventricle is hypertrophy, what's going to happen to the volume of blood that could go into the left ventricle? Rise or fall? I said if you got hypertrophy of the left ventricle, what's going to happen to the volume of blood that can enter the left ventricle? Rise or fall? Remember, you said hypertrophy. All right? Now, hypertrophy has two phases, just so everybody understands, because her answer could be correct if we're talking about what depends on what phase you're talking about. Hypertrophy has two phases. When you hypertrophy, first you hypertrophy within the walls of the ventricle. When you hypertrophy within the walls of the ventricle, Tony, the ventricular space is still the same. What happens to cardiac output? If the volume in the ventricle stays the same, Tony? The cardiac output stays the same. And therefore the heart rate stays the same. Second phase of hypertrophy. Now you hypertrophy too much, and then you start to obliterate your own ventricular space. What happens to the volume in this left ventricle now, Tony? Decrease. What happens to cardiac output now, Tony? Decrease. What happens to your heart rate now, Tony? Increases. That means if you tell me somebody has hypertrophy, and that's for, all I do is I look at the heart rate to know what phase they're in. If their heart rate is still normal, you're still in the early phase. That means volume didn't change yet. If they give me a tachycardic patient, they've already told you it's in the second phase. Now, I rarely ever meet a student that ever picks that up. They just keep on reading. That's it. Again, pulse means nothing. It's just a number. That's why I said, folks, you got to know the physiology of every vital. Okay? They tell you about a heart rate, which phase of hypertrophy you're in. Okay? So, anytime you have hypertrophy, that's why they say diastolic dysfunction. Because you're going to lose ability to fill. That's diastole. So whenever you have hypertrophy, we call it diastolic dysfunction. Everybody clear about that? Because you're going to have to lose the ability to fill the ventricle. So anytime you see that term in any vignette, diastolic dysfunction, they already told you it's a resistance problem, hypertrophy, S4, and we can go on and on. Everybody follow that? All right. Because anytime you have dilation, the most common, that's a systolic dysfunction because you lose your contractility. Remember Frank Starling law? Separating the cross bridges. All right. Tim, you got a question? Yes. Yes. Linda! Stand up again. I want to see how tall you are. I think you grew in since the last time. Yeah. Okay, stand up again so everybody can see how many inches you've grown. All right, so here we go. All right, everybody listen up. Nobody write a thing. Just listen to Linda. We're going to go through one real fast. I'm going to show you how it's done. You ready, Linda? Now, follow me carefully now. Physiology. Don't let the mind guess it. Follow the physiology. So let's say you got a pulmonary embolism. Is that going to affect your S1 or S2? S2 is going to be affected. Is that going to be louder or softer? Louder. All right, so what's going to happen to pulmonary blood pressure if you got a clot in the way? It's going to rise. What's going to happen to pulmonary resistance with a clot in the way? It's going to increase. What's going to happen to pulmonary blood flow? It's going to have to decrease. What happens to S2 splitting, wide or narrow? No. Remember, the widening is based on volume going into the lungs. You just told me there's hardly any volume going in. Then the valve will close faster. That's a narrow S2 splitting. Do you understand? Is this a resistance or volume problem? Resistance problem leads to hypertrophy or dilation. Hypertrophy leads to an S3 or an S4. No, S3 is volume. S3 is volume. You understand? S4 is resistance. So high resistance. That means hypertrophy leads to an S4. Would this S4 get louder when you breathe in or breathe out? No. You have more blood flow to the right side of your heart. Do you understand that now? Well, that means everything on the right side gets louder when you breathe in. Do you understand that now? That's always going to be true. You understand that? Everything on the left side gets louder when you breathe out. You understand that now? Okay, so you got an S4 from hypertrophy to the right ventricle. Is it going to get louder when you breathe in or breathe out? When you breathe in, because we're on the right side, right? Okay. Is the right ventricle going to contract harder or softer? Harder. So does that make S1 louder or softer? Louder. So what effect will that have on your central venous pressure? The blood sitting outside right atrium, rise or fall? It has to rise. Wait a minute. If you got hypertrophy of the right ventricle, what part of EKG tracing will pick that up? The QRS complex will change how? No, it's going to be tall, but not wide. Wide is dilated. So it's going to be real tall. And if you want to be sure that is really the right ventricle you're looking at, what lead are you going to look at? V1 is right over the right atrium, though. I want to see the right ventricle. No, V2 is over the left atrium. Now you're going to the other side. What lead sees the right ventricle? Lead 2 will have a tall QRS complex. That's how you know. You can sit down. See that? See what you can do when you try? You just gave me all the cardiac, pulmonary manifestations, and EKG findings for somebody's got pulmonary embolism without my having to teach it to you. The physio is in your minds now, folks. Stop the guessing. No more guessing. All right? Because, I mean, after Dr. Shaw went through these sounds, and then he starts asking me questions. All right, what do you get when you have this? I got it right. What do you get when you have this? I got it right. What do you get when you got this? After about 7 or 8 of them got it right, he says, right, you're right, you're right, you're right, right. I said, wait a minute. What do you mean I'm right? You better check it out, man. I don't think I'm right. I've never been right that many times in my life. He said, no, you're right. That's because all of a sudden I could see the physiology. I could process his question as fast as he's asking it. I didn't have to stop, stall, and then come up with the wrong answer. I just could see it as soon as he said it. I knew exactly what the answer was.